Awesome.
Do you want me to do the opening housekeeping?
Sure.
All right. Hi, everybody. Thank you for joining us for this work group meeting. I've hit the record button, so attendees are advised that this meeting is being recorded. So anything said verbally, anything viewed via webcam, or anything typed in the chat area will become part of the recording that Julie will post to the web. Please mute when not speaking. The buttons at the bottom of the screen obviously are the microphone on and off button, the leave call or leave the meeting button, and then the video camera on and off button. I learned a lot about the raising hand button yesterday, so we can organize people to speak that way, or if there's just, it's like we're going to be under 10 people, I don't think we'll need to use that. They're a small group. Julie's going to be displaying group materials for the group, so there's no need to present your screen unless there's something to share. And if you're just on the phone, please identify your voice before stating your remarks. Thank you.
Thanks, Shelley. Okay, so we can go ahead and get started with some introductions. So I can go first. I think I've met all of you, but just in case, I'm Julia Vinton, the EMS for Children Coordinator at ADHS. So I see Dawn, I see your face on the line. Thanks for joining. Do you want to introduce yourself?
Sure, good morning. I'm Dawn Bailey. I work as a family advisor for the Office of Children's Health and the Children and Youth with Special Health Care Needs program in the Bureau of Women and Children's Health.
Thank you. Heather, do you want to introduce yourself?
Yeah, my name is Heather Miller. I run all the EMS and trauma for the Kingman area, and that's my job.
Thank you. Jordana?
Hi, it's Jordana Carpenter. I'm just a parent that has special needs child.
Thank you. And then I see Dawn Darling. I love all the Christmas trees in the background.
My name is Dawn Darling. I'm a clinical supervisor at Phoenix Children's Hospital in the emergency department, and I worked trauma for a long time before that at PCH.
Awesome, thank you. And Shelley, do you want to introduce yourself as well?
Good morning, everyone. My name is Shelley Bissell, and I work for the Arizona Department of Health Services Bureau of EMS and Trauma System, and I help coordinate stakeholder meetings.
Thank you. Okay, so just going down the agenda, I'd like to review the minutes from the last meeting. So we have met as a group before. However, I do think it's a different group of people, which is really nice. So last time, Jordana, you attended. I think that's the only overlap. So that's awesome. I'm glad that we have some different participants today. But we don't have to go. We don't have to go through all of the notes. But essentially what we had decided at the end of the last group meeting is that we wanted to focus on two primary areas, the ABCs, airway, breathing, circulation, and then some sort of communication and engagement with parents and caregivers. So as a result of that, I had started a Google Doc just to kind of get some information compiled. Not a lot has happened, honestly, since then. So I'll just kind of open it up. Does anybody have any questions or anything like that regarding the last meeting? No questions? Okay. Well, we can kind of, I guess, let's start by So first of all, those two topics, is everybody in agreement with those topics as starting points? Does anybody have any feedback?
I think my only request would be to add neuro in with it, especially in the special needs population. We find getting a lot of kids from EMS is that they don't know how to do a neuro assessment on someone whose baseline maybe is a little bit different. And we put that pretty high, right up there with ABCs. So I wonder if we should add that.
Yes, thank you for that feedback. Let's put that. So would you say neuro assessment? I'm not starting this up. Okay. Neuro assessment would be the accurate title for that.
Absolutely.
Okay. Okay, awesome. Does anybody else have any other feedback or comments or questions?
I would just add, I like that idea of adding that because I think that, like what Dawn said, a lot of our kiddos, their baselines are very, very different. And that can be a challenge in communicating that when you're dealing with EMS with that initial call for transport. So I think that would be an important thing to add.
Okay, awesome. Okay, so we can add that to the list. I'll just kind of show you what I had compiled. Let's see. Okay, so I had basically kind of looked at some other documents that EMS for Children programs and similar programs had put out, and then broke down these kind of starting points. But I would just really love more feedback and just kind of more input from, I don't have a clinical background, so that's where you all come in terms of really getting into what kind of guidelines and things that we would include for that. So yeah, I'm just going to open up the floor for discussion on specific considerations, things like that we would include here. And I'm just going to also show really fast, this is just a document that another EMS for Children program had put out. So recommended EMS guidelines, this is from 2009, so I'm not sure if things will have changed, but it could be a starting point in terms of looking at what they have written.
Is that attached to the meeting invite?
It's linked in one of the documents, so it's kind of a couple of links in. Let's see.
Can you expand the visual?
Yes.
And if you can add it to the meeting invite, then I think everyone can manipulate it.
Great idea. Let's try to do that.
Look at it separately if needed.
Hey, Julia, sorry I showed up a little late, so you may have already gone over this, but the subject is ill-defined. I mean, have you guys been able to define what a child with special healthcare needs is or are?
That is a great question. And we basically, so far, we just kind of reviewed the notes from the last meeting. So I don't think, were you at the last meeting?
I'm sorry, I'm not 100% sure. I've been so busy.
Oh yeah, no problem. Okay, I don't think so. Yeah, so this is basically a completely different group, which is really good actually, so that we can have more input and discussion. But so at the last meeting, we kind of identified the work group objective. I don't think we necessarily identified a definition.
No.
So if that's something that you would like to do, then that would be great.
Me and Dr. Augustine developed a slide deck that I can send to you, but the United States Department of Health and Human Services has a definition, and it's just so broad because it's essentially anybody who requires health and related services of a type or amount beyond that required by children generally. And that's like, statistically, that's 20% of US children under the age of 18. 1 in 5 US families have a child with special health care needs. So what we did, and I would probably recommend, is the majority of EMS agencies, when they're going through paramedic school, they use a curriculum called Nancy Caroline's Emergency Care in the Streets. And the stuff that they go over, we thought was kind of the important stuff, where EMS was going to have, life-saving interventions and those kinds of things. But I can send the slide deck out to the group after we're done, if you want, or now.
Yeah, that would be great.
Okay.
I would also add, in addition to that definition that Chris just mentioned, for a lot of like our MCHB work, we also kind of have a caveat group within that of children with medical complexity, so CMC population. So I don't know if, and there's not really a defined definition of what qualifies a child with medical complexity. A lot of times it's if they have 2 or more specialists or, kind of thing. So I don't know if you wanted to look at that to kind of define it a little bit more, but it is broad. And I think, so you would also include like behavioral health, diabetes, asthma would be children and youth with special health care needs. So just to kind of throw that out there as well, if you're talking about definitions.
Yeah. I found another definition that I found helpful from a private organization online, and they said the 4 major types of special needs children are physical, developmental, behavioral, emotional, or sensory impaired. And obviously, to kind of piggyback on what Don Bailey said. Sorry, Don, I don't know who you are. It's kind of difficult because if you're going to starting to go into the behavioral and emotional, that includes autism and a whole array of biobehavioral and psychiatric diagnoses, and that's pretty broad.
So do we want to pick 1 or 2 of those areas to focus on, or?
This would be my recommendation. Obviously the physical, so you look at stuff like muscular dystrophy, multiple sclerosis, chronic asthma, epilepsy. Developmental, so like autism, Down syndrome, the trisomies, processing disorder, stuff like that. And then of course sensory impaired, hearing impaired, visually impaired, things like that. The behavioral and emotional one is such a range. It's really, really difficult. And, the state's already doing work on the administration of ketamine, and so is VMD. So like once we get into that, we have to go into like sedation and those things. And to me, that's probably something we want to stay away from. That's just my opinion.
Okay. Does anybody else have any feedback on that?
I would maybe just kind of piggyback on that a little bit. So, Chris, I work with the Office of Children's Health with the children and youth with special health care needs as their family advisor for our maternal children health Title V program. So a lot of our programs follow like the HRSA guidelines and NCHB. One of the things some of the other work that I'm involved in, like around like care coordination and improving systems of care, we really do try to hone in on some of those more complex categories first, because there's kind of this idea that if we can create processes that can work for some of those most complex, it's a lot easier to kind of funnel down across like the general, like your with 2 comorbidities or your generalized population. So I don't know if that same application might be beneficial here, is if we try to think about some of the more complicated, aside from the behavioral emotional, because I kind of agree with what Chris was saying. That is such another dynamic that I think that has to be viewed and approached very differently. And and then build up from there, if that makes sense. So I don't know what everyone else thinks, but traditionally we feel like if we can create something for the hardest, then it's easier to kind of disseminate across the other categories. So
that was very well stated. I think what I can do after is I can send out the chapter 43 and that paramedic curriculum, and everyone can take a look, and it pretty much said what Don said.
Hi, Dr. Woolridge.
Hello, my apologies. I'm sure it's the same everywhere, but yeah, it's a little bit of mayhem down here, so forgive me for being late.
No worries. We were just discussing the 4 areas within children and youth with special healthcare needs and how we might approach each of the areas. So Dawn Bailey was just kind of describing that in some of her past work, they've started with the most complex, which is likely the behavioral/emotional, and then kind of moved on to other areas because it can make other areas more approachable. Does that reflect what you were saying, Dawn?
actually, I was saying not necessarily the behavioral and emotional. I think kind of what Chris was saying, we have to kind of look at that very differently because there's a lot of like crisis intervention that happens with that, but more like the complex medical aspect.
Okay, I'm sorry, my mistake. I got the complex part, but I was applying that to what Chris was saying about that being the most complex. Okay.
It is complex for sure. Yeah.
And Dr. Woolridge, we were just saying that, children with special healthcare needs is not really defined. And there is a definition. It's very, very broad, and it's the United States Department of Health and Human Services. And I can just read it, but it says, those who have or at increased risk for chronic physical, developmental, behavior, or emotional conditions and who require health and related services of a type or amount beyond that required by children generally. That's a very broad group. And so I think me and Don are on the same page where we suggested that we categorize into physical, developmental, behavioral, emotional, and sensory impaired, but kind of stay away from or put it secondary for the behavior emotional, because we're going to start getting into things like sedation and ketamine administration, which the state and VMD, at least locally, is already kind of working on. So that would be my opinion, to try to focus on the physical and developmental and sensory impaired first.
I think that's a great strategy. That being said, behavioral emotional approaches in the field, particularly with restraining or immobilizing or redirecting an individual, I think is going to be something that would be helpful. But you're right, this is huge. And I think you have a good strategy on tackling this for sure.
I'll send those documents out to the group, Julia.
That would be awesome. Thank you. Okay, so agreed to focus on the physical. Sensory impaired. Okay, so when we are discussing like the ABCs or neuro assessments, are we going to need to develop, well, each of these categories kind of fit into a document like that that overarches all of them, or will we need separate kind of things for each category?
Are you talking, I saw on the notes you guys talked about like a pocket card last time. And all of those things would fit on one pocket card.
Okay.
I mean, I can share some data from here, and I think NEMSIS may have some data on this. I don't think we're not going to be able to query like tracheostomies, but we can definitely see like the major reasons 911 is called throughout the country for pediatrics. Seizures is a big one, and it's often missed. EMS really struggles with that, and we see that here too. But I can kind of share data with you to see what the most common reasons these children are calling 911 for. Off the top of my head, I can tell you it's tracheostomy and seizures, without a doubt. And then, are we going to include things like a central venous catheter with the fever and sepsis and those kind of things? So we need to define this from the very beginning.
If I can, maybe probably more for my benefit than anything else, to get the 10,000-foot view of all of this, and maybe it's just my bad habit. I'm a pragmatist. What tools do we envision coming out of our work, and knowing that, how do we extend this broad enough of a category and essentially chip at it? Should we, from the top down, and then work towards tools, instruments, resources for Arizona EMS? Or do we say, okay, we want to build X, Y, and Z tool within these categories, and then focus our work on the individual tool? So for example, you say tracheostomies. If a paramedic in the field is working with a child with the tracheostomy, what resources can we make available to them? Would it be a video of the different technique devices? Would it be reading information? Would it be an algorithm or a protocol for guidelines of work in the field? Each region of EMS in Arizona kind of has a set of guidelines. Clearly, they're not going to be focusing down like we want to do. So anything we build would very, very much be, I think, helpful to each region. But what does everybody envision as a product of this work?
So I was kind of talking in the beginning about at the very first meeting, which happens to be a completely different group of people than is here today. We had talked about producing some sort of materials specifically related to the ABCs, and then also for EMS interacting with parents and caregivers. So we were thinking potentially like some sort of little pocket card, or just resources specifically assisting in those areas. So again, I'm not sure if that would be videos or if it would just be like some sort of general guidelines or document or pocket card type situation. But that's what we had discussed at the last meeting.
Okay.
When I work as a paramedic, I think that all those things would be very, very helpful. I think the big things that paramedic are looking for are what's the complication, associated with, technology assisted children. What are the complications we have to focus on? I also think it may be helpful to potentially to bring stakeholders in, like family members of a child that call 911 a lot. Because to be honest with you, what I tell when I teach pre-hospital people is listen to parents. They're going to know how to do the suctioning. They're going to know about the BT shunt. They're going to know about the Glenn and the Fontans. Listen to parents. More often than not, they're going to know if the child's seizing or not. And so maybe it'd be helpful to bring somebody in with a child that suffers from some of these anomalies.
So we have two on the line. I think Jordana and Dawn are both family members or parents of children that fit into this category.
Oh, sorry about that.
No problem.
Yeah, no, I would agree with that, because I think, and I'm sure Jordana may have something to add to it as well from experience, but oftentimes, especially with some of the complex kiddos, we kind of have our protocol like at home, but then if it gets to a point we have to call 911, if the paramedics arriving aren't familiar, they kind of have their checklist, and oftentimes they don't meld well, and so there's that disconnect. And so what I would say as a user, so to speak, is that whatever we come up with should help supplement the knowledge for the EMS to be able to come in and feel as comfortable as possible, understanding the complexity and how to work with that specific like knowing you're going to walk into a door and it's not going to be a checklist. Like you're going to need to know your basics, but you also have to understand that this child is probably going to be very complicated and unique. And to what you said, Chris, the family is going to know a lot of information that's going to help and how to work together instead of feeling like there's like a disconnect sometimes between, you know, we have our set things we have to do and families are saying, no, this is what I know. You know, my kids' vitals are typically like this, or, you know, their baseline is this. So I would envision whatever we come up with helping to facilitate that collaboration better in the home to then assess, is transport needed? And if it is, then taking those next steps. So
one of the things me and Dr. Augenstein really stress when we teach, pre-hospital people who don't have a lot of experience in general with pediatrics is whatever you can do before you get to the call to decrease cognitive load to prepare you, you should be doing that. And so, for example, we have a kid here with Dravet syndrome, and I realize we can't do this for every patient, but we have a very individualized protocol. So when they're dispatched to the call, hey, this is so-and-so, they have Dravet syndrome. Remember, we have a special medication we give them. The mom's an ICU nurse. She's waiting for you guys. And so, I'm not saying we can, that'd be a huge project, but I know some smaller systems categorize kids and they have catalogs of, hey, this kid lives at this address. And when 911 is called, the address is flagged on the way to the call. They're able to kind of research, oh, this is Dravet syndrome. I know that's a big thing, but maybe starting with dispatch, and I'm not sure. It's something to think about.
I would agree. We are fortunate where we have the ability to have that. They call it a premise alert. So it's in the dispatch system, like our address. So if they're dispatched, something pops up to give them an idea of what they're coming to. If it's a medical call and if it's a fire call, where our daughter's bedroom is for evacuation purposes because she can't self-evacuate. So I've been touting for years that I wish all dispatch systems in Arizona could have some sort of opportunity for all agencies to utilize that, because even our agency here has said time and time again how helpful that is. So I don't know what if we could in tandem work to promote that, but I think that's absolutely a huge benefit.
I'm curious if I have contact with Seattle Children's kind of bit. I wonder if Medic One. I realize it's a much more simplified system, but maybe I'll reach out to them and ask them. I'm not a big person of reinventing the wheel, so I'm sure other states and other systems have done this. So if anyone has contacts, I can work with CHOPS and Seattle Children's to ask them if they have something. But I think we should start with asking. I love the idea, Don, of doing something like that. I've always liked it, and I think it's a great idea, no matter how big the undertaking.
Yeah, that's a great idea. I'll also see if any other EMS for Children programs have promoted or anything similar, and if so, what their role was in that, because I'm not sure exactly what the role would be. But I think that's a really good idea and something to research for sure.
I'll stop talking after this, but I to simplify things and trying to begin with the end in mind, as Dr. Wooldridge said, I probably would recommend starting with something simple like technology assisted children. And we defined that at our hospital as tracheostomy tube, gastrostomy tubes, central venous catheters, and CSF shunts. And that's kind of how we taught. We work at the Phoenix Fire Department to really address those 4 things first. That would be my suggestion. It's just there's a lot of information, and we can kind of have some success on the front end of. I'm not sure.
Yeah, your input is very helpful. So you don't need to stop talking. Okay. Yeah, that sounds like a good focus area to begin with.
Yeah, and maybe I'm overreaching a little bit too. I like the card concept. That being said, the individual in the field doesn't necessarily have the time to sit down and study a card prior to getting on scene, nor time when they are already on scene. And a lot of their interventions requires a degree of understanding of the physical items they're dealing with. Again, maybe referring back to the tracheostomies. There's a motor memory component to that too. I understand that in the COVID era, in-person education is not always practical, but videos are helpful too when it comes to demonstrating devices and use of devices. So if we are going to, and maybe I'm too much focusing on the educational side, but if we are going to create some modules, it might be worthwhile to have images and or videos that augment the tools that they will have in the field, like the pocket card.
I love the idea of videos.
Yeah, that's a really good idea. Let's get right down here. Okay, so when it comes to starting with this, what would be the best way for us to collaborate on kind of identifying specifically what material we want to be promoting? Does it work for a Google Doc like this, or is there some other kind of way? Do we want to start writing things down now, or?
So,
Chris, do you have, oh, sorry, go ahead.
what would be our initial objective?
The initial objective, I think, to identify the key messages, the key messages that we're trying to promote. What kind of things will we be focusing on if we were to create a video?
I mean, Don, what would you say is the most acute, both Dons actually, because Don Darling has a lot of experience with this as well. What do you think the most acute patients are with technology-assisted tracheostomies, right?
Yeah, well, I think the most common, hands down, you said that, and I think they're very scary. So absolutely, I would go with tracheostomies. I also like the idea of just starting with the ABCs and neuro, but maybe just putting a lot of talk about tracheostomies and ventilators in with the breathing and airway. I know we get a fair amount of kids that ventilators are broken and kind of what to do in that situation. So including medical equipment in those ABC neuro categories, I think would be important.
I would add G tubes to the list, or any type of feeding tube.
Absolutely. I agree 100% with that, with G tubes. It's just not necessarily like an acute emergency, with the exception of like putting a catheter in there so it doesn't close.
I don't think there's a high volume of calls for G tubes. I think most parents, they change those out at home unless it's a GJ. And it's not, they can call their physician. They can, I mean, at the last resort, come into the hospital, but they know that that's a car ride, not a EMS ride. The parents can correct me if I'm wrong, but that's a really low kind of acuity emergency, and I don't see a lot of EMS usage for that.
And when they call in and ask questions, and it's maybe 1 or 2 times a month, and I can share the data with you, but generally we're just like, hey, do you have a long transport? Yes. Can you ask the mom, because EMS typically won't do it, can you ask her to put a Foley catheter in just to maintain the stoma? That's the most we do. I think understanding why a child has a gastrostomy tube, if a child has a gastrostomy tube for dysphagia and risk for pneumonia, that's how I teach it is, understand why the child has a gastrostomy tube.
Yeah. I guess I'm thinking a little, working in a pediatric emergency department, the parents do routinely come in if they're out or if there's dysfunction or if they just don't know when they could wait till the next day. If the parents don't have transport,
Sure.
then the paramedics will default to transport, as opposed to maybe understanding of which ones they could treat and release. So maybe understanding the needs and what is critical, so they can temporize in the field. How many paramedics know how to insert a Foley? I know the parents probably do, but do they always have a Foley backup? I unfortunately see a number of parents bringing their children in, and that's what we do, is we either find the replacement Mickey or we put a Foley in. So if we are in a rural area and if it's a potential for a treat and release, I think there's benefit for the paramedic to understand G-tubes a little bit better. I agree they're not routinely emergencies.
And I would piggyback on that is oftentimes, even when it comes to tracheostomy stomas, when we ask them to replace the trach, they'll say, oh, no, that's not in our scope. We got to do an EP tube, or we actually intubate through the mouth. And so maybe this brings clarification on whether, replacing a G tube with a Foley catheter is even within their scope. By the way, Dr. Woolridge, do you think it's in their scope?
With adequate training, yeah, airway management should be.
Oh, specifically a gastrostomy.
Oh, the gastrostomy. Oh, yeah. If it's a G tube, I'd be a little bit hesitant about J tubes.
Yeah.
But with G tubes, for sure. If they're anywhere over a month old, they're pretty stable.
But do you think it's within the pre-hospital provider scope within the state to do it, to put a Foley in?
Oh, on the legal front, I would have to throw out a lifeline and maybe talk to the bureau to confirm that.
Yeah, the majority of paramedics default by saying that is not within my scope.
I'll counter as a parent. If I'm qualified after 1 month or, to change out my daughter's G-tube at home, on my own with no medical supervision, I think we can talk about adding that to the scope or ensuring. We put a lot of trust in parents to be able to do a lot of these things. Like, we need to be pragmatic about that.
I would agree with
my daughter's G-tube. So yeah, I think it's not, yeah.
I would agree with Dawn. As a parent, my scope of practice for my child is a lot greater than what EMS can provide, with or without my medical training background. We had home health come in and show us, and both my husband and I can pretty much handle anything. If I'm calling 911, it's for an actual emergency, not to replace a G-tube.
Yeah, but I do agree having them have the ability to help with that in the field, because I would say, while it's not necessarily an emergency, I know that, and maybe even like we talked about rural, but even not rural, insurance is a nightmare with these type of supplies. You get one replacement Mickey every 3 months. And if something were to happen and you had to change, you don't get another one. So if you have an issue in between, that's oftentimes where parents are going to struggle to be like, what do I do? And so if we can help alleviate that in the field, one, if it's putting in a Foley until they can reach out to get something ordered or get a prior authorization, it saves an emergency room visit, it saves a transport cost, things like that. So I think having that knowledge is definitely beneficial. If there's something you can do in the field to prevent having to transport or prevent families from having to unnecessarily access the ED. So
I think some knowledge that would also be beneficial is to let them know that the stoma closes very quickly. It's not like a trach stoma that is open for a while after it's been in for a certain amount of time. A G-tube stoma could be in for years and can close within a matter of, 2 hours.
I agree. I think we still need to define what our initial objective is, and what the, like Dale Woodward says, like what's our initial objective, and then from that objective, what's the outcome going to be? A video, or are we going to tackle one subject at a time, or 7 subjects at a time? I really like the idea of getting dispatches involved and cataloging cases. I know that's a huge project, but that's something that I wanted to do or bring attention to for a long time. I think it would help EMS so much. So I think that's a larger project, but that's something I would really like to focus on.
I like that as well.
What would y'all sorry to interrupt. What would y'all think about polling the regions or individual EMS agencies and kind of ask them, what are their education gaps in regards to special healthcare needs, and maybe approaching it in that manner, kind of the low-hanging fruit approach of where the gaps are, identifying those, and working towards that product in that manner.
I think that's a good idea. I would maybe also suggest that we help them understand the area. So, if you have EMS who've maybe never responded to a tracheostomy call, it might not be at the forefront of their mind to say, we don't know about tracheostomies. So it might be good to say, what areas do you feel you need more training on in relation to tracheostomies, G-tubes, to kind of help get them to think about these other, because we often find if they've never experienced it or they don't know about it, it's not something that they're going to think about that they need to know about. So.
Yeah. Again, I really like the way Nancy Caroline's Emergency Care in the Streets, it's chapter 43. I really like the way she catalogs children with special healthcare needs, and I can't find the chapter, but someone's going to text it to me now, and I'll email it to the group. And I think that may be a good, but that's a national curriculum, so that's something that we can expand on, that every paramedic student is theoretically getting.
Chris, is that public source? Excuse me, is that public source or is it a copyright chapter?
I'm sure it's a copyright because of it's a paramedic book. I just purchased it for somebody and it's expensive, so I'm sure it's copyrighted. Yeah, probably. But we could. That's how we started our slide deck for EMS, and again, I'll send that out to the group as well. Yeah, absolutely. It doesn't mean it can't be referenced. So I'd love to see it.
Dale, I like that idea of the survey. The one concern I think right now is just how much communication is going out to EMS agencies and things like that. And the National EMS for Children survey is going out in January, which is also surveying EMS agencies. So I'm not sure if right now would be the appropriate time to do something like that, if that makes sense. But yeah, I think that would be a good idea at some point. It might narrow our focus or help us, but I appreciate what Dawn is saying, is that what they don't know, how do they know what they don't know? That being said, if we could handpick a couple of pediatric champions, regional pediatric coordinators, and maybe just touch base with them independently. Yeah. And as opposed to polling everybody, just throw out a couple of lifelines. It might give us a starting point, but I agree. I think everybody's a little bit overwhelmed right now.
Hi, Julia. I wanted to quickly interject. So I'm Laura, and I work with Dawn in the Office of Children's Health in the NBWCH Bureau of Women's and Children's Health as well. I just wanted to, before I hop off, Dawn is definitely the contact for this area. She does, communicate and provide updates. I just really quickly wanted to share that if we do, or the group goes in the direction of using videos or even the pocket cards, please let me know how we want to proceed, or if there's funding needed, because we would definitely be able to tie funding or budgetary needs to our Title V MCH block grant, Children and Youth with Special Health Care Needs budget, for projects like this, so that way we can make sure they get started. We don't have experience creating those videos, but Julia, we're internal, so if it's just a matter of me sharing our function and PPC to put together a purchase request. I just wanted to let you guys know that that's something we can work with within our budget.
Awesome. Thank you so much.
All right.
Really
Well, thank you so much. Thanks, Dawn.
Okay, so I really like the idea of the video at some point. I'm not sure if we want to jump right into such a large project as our very first project. Does anybody have any objection to kind of starting smaller with like a pocket card or something along those lines?
What, like, let's just take a quick subject and what would be on, like, let's say technology assisted children, what would be on a pocket card?
I mean, that would be up to you, the group, in terms of what the most important messages that we're trying to get out are.
You can give a card that say, listen to families, don't let your pride get in the way.
Yeah, so I had started to compile some information like that, and one of the documents that I had shared, let me try to figure it out, find it. But just on some other, I had done a little bit of research, and so there is out there, of course, information on this. So if we wanted to kind of summarize that and put that on a little card or something like that, that would be a pretty easy project, I think, for the group to at least accomplish right out.
I think a pocket card, those are things you need to be able to pull out of your pocket in the moment and say, this is my drug dosage, or this is the GCS scoring system on a 9-month-old. I think reading like information about family-centered care and listening to the parent, like Chris said, there's not much more to say, but listen to the parent. So I don't know if a pocket card is the right method for EMS to kind of learn about that. I think that's definitely like a video thing or some sort of other like longer instruction. I'm sure they have a lot of pocket cards. I have a lot of pocket cards, and I have access to a lot more working in an ER than they do out in an ambulance. So if we're asking them to hold on to one more pocket card, I don't think this is the one they're going to hold on to.
I would tend to agree with Dawn.
Okay, what about like an online resource? Do you think that would be something that would ever be used? Like if we had like on the Bureau webpage or something like that, like just kind of a resource document, would that be beneficial, or no, we just want to go in the direction of like a video?
But I don't think the EMS will look online before they go to a call.
Okay.
I was just going to add, it may translate and it may not. So I'll let you guys give me your feedback. But we have, I do a care coordination curriculum in partnership with the General Pediatrics Division at PCH. And there's a module on family professional partnerships. And so, and we can adapt the curriculum any way we need to apply it, but it could be that if you're looking to do like a video or something, we could include kind of like part of that module on what does like family professional partnership mean, which is really listen to the parent, but it kind of gives a little bit more of that guidance to a provider standpoint of why that's important, what that looks like. And that might be more impactful, maybe, if we kind of tie that together. And then I would also say that when we've rolled out this curriculum to like clinical, we've always had families part of it to share that personal experience, because giving a face and a real life experience to something, I think really resonates and sticks with those that are doing the training to kind of remember why that is important. So maybe something to consider if we do some videos is adding that to that as well.
I think if there's already a module out there, is that something that we can work into some sort of CME hours or contact hours? I think that's usually a good way to get engagement. If this is just a resource out there, I don't know if it's going to be one that is looked at.
I'll send you the curriculum and you can look at the different, there's 6 modules. So the one on family professional partnership is module 2. You can look at it. I do believe it's out of Boston Children's. I do believe that it has been done in conjunction with some CME work because it is adaptable. We haven't done it for CME at this point because we just didn't have the resources to facilitate that. But if you want to take a look at it and let me know if it's something you think you could incorporate with like a tracheostomy training or something for CME, we can adapt it to whatever we need it to be. It's very adaptable. So.
So would you mind you would share that with the group, Don? But yeah, I think CE is a really good thing to consider as a way to get EMS providers engaged. Oh, thanks for sharing that, Chris.
No problem. I know it's a big undertaking, but it's going to be hard to get. And then we do CEs every month with EMS. It's going to be hard outside of, pending National Registry application for recertification to get buy-in for people to like do stuff online, or there has to be incentive. And I'm just curious if we could really do something if there's technology out there, or there's something that we could do to work with dispatchers on the way to the call, somehow providing a resource on the way to the call. Cause like we have a quick reference on Dravet syndrome that Buckeye Fire will read on the way to the call, and it's only 5 or 6 points, benzodiazepine resistant, just things like that. But to me, I really like that idea of doing something before they get to the call, some quick reference that they could look at. I'm not sure. I don't know.
Chris, are you talking about like in the CAD system that's where it's at?
Yes. Yes.
Okay.
I realize that's a very big undertaking, but I'm sure smaller systems do that.
Yeah, I'm happy to help in pushing that forward as well, Chris, because like I said, we've been a benefit of that. We're here in Chandler, so the Chandler Fire Department utilizes that through the Phoenix Dispatch. But I will say we recently moved a couple of years ago, and we're right on the border of Gilbert. And so sometimes we have Gilbert respond, and Gilbert uses Mesa. And so our premise alert does not activate for those if Gilbert is dispatched. And we run into a couple of hiccups with that. So yeah, I'm a huge proponent of, I think that is beneficial across the board for everyone. So if you have ways of approaching that, I would be happy to help in that from the family perspective as well.
I would like to do that as well. I think that's a great idea. We also have a lot of medical fragile kids in schools.
Mm-hmm.
A great system to hook up with them as well, because they have a big population in some of the schools that have medically complex children, not just autism, but medically complex children.
Agreed.
There's an organization in Arizona that they work. I'm ashamed to say I don't remember the name. I'll figure it out now. But they work with all the public schools in Arizona. They're nurses and healthcare providers, and we do education with them. And they participate in our annual conference. This may be a group that we wanna bring in on this.
Is it the School Nurses Association?
Yes, I think that's what it is. I'm looking it up right now, but yes.
Yeah, we work with them as well. I think they would be good. The challenge, and I'll be honest, a a lot of our districts our schools no longer have nurses on campus. And so like you have 2 district nurses. So you have health aides on campus, even with like our more medically complex kiddos. So it's oftentimes hard to get that info. Like the School Nurses Association does a great job. I work with Nadine and Tina Mahoney on a lot of other things. And, but to disseminate that down and get the districts to buy into a lot of that has certainly been a challenge. So not to say it's not worth it, but I think sometimes focusing local with like, I think like if we could work with like the fire agencies locally to push that to the schools, that would be a better way to get the schools to buy and the districts to buy into wanting to do more work on that.
Sure.
So.
It's an overwhelming undertaking for sure, and I'm not sure where to start.
Well, I like starting with like the tracheostomy and maybe just focusing on one condition, see how it goes. You know, how does rollout, how does training, what does that look? And then I think we build on it. It is a lot, and I'm sure Jordana can relate to this too. But living this, it's a lot. Sometimes we just have to take one area of focus and work on that and build on that. So I think if we start small and make sure we can do it effectively and well, then we can roll it out more broad better than trying to do too much at once. So.
Agreed.
Yes, I agree. And I know that we're close to 11 o'clock. So I just kind of want to wrap up the meeting. I really appreciate everybody's feedback and discussion. I know there's a lot of parts to this, and it's kind of hard to narrow down, or at least I'm having a hard time narrowing it down to one specific project. But I think I agree with what you were saying, Dawn, if we just kind of choose that one area and try to do something with that, and then we can kind of expand while also kind of doing research. For example, the dispatch center, seeing what other people have done. I know, Chris, you said that you can reach out to somebody, and I can also look at what other states have done with EMS for children specifically. But just to kind of get some action items, I think if we focus on the tracheostomy focus area like we just discussed, kind of identifying what method we want to distribute that information or compile that information would be a great thing for us to do right now before the meeting ends. Or we can just kind of continue to brainstorm if that is what everybody feels like is the best thing.
I mean, I think it's imperative that we do not reinvent the wheel. And I think all the documents that everybody mentioned, everyone look at that documents to kind of determine where we want to start. And I'm waiting for that curriculum, and I'll send that too.
Okay, that sounds great. Okay, then, yeah, let's just do that. We can all do some research. I'm going to keep this document right here available. If I haven't shared it with you, I'll just make sure that everybody has access to it. So if you have any resources, that would be a great place for you to share them, or email them to the group. That's also fine. But if we want to kind of review what's already out there again, so we don't reinvent the wheel, and then kind of decide where we go from there, that I think that would be good. If everybody agrees with that process for going forward.
Sounds great, Julia.
Okay, awesome. Okay, anybody have anything to add as we kind of close the meeting?
How often are we meeting?
That's a great question. So this work group has only met once before, but just because of the nature of it, I think it would be good to have a consistent meeting. So, I mean, our PACES meetings are every 4 months. So our next PACES meeting is in March. If we want to meet again before that, that would probably be a good idea. So I can send out a doodle poll in January if that works best for scheduling the next meeting.
Yeah, that works.
Okay. Awesome. Okay. Anything else from anybody?
No, thank you all. Appreciate working with you.
All right. Thanks, everybody. Have a great day.
Thanks,
Thank you.
everybody.